Welcome to Medicine Grand Rounds. This month or this week's presentation by the Division of Geriatric Medicine is going to be given by Katherine Brennan, who is an assistant professor in our division after joining us in August of 2018. I have refreshed my memory of her itinerary coming to Richmond. So she started out near where I grew up in Massachusetts at Tufts, going to Tufts in Medford and learning about community health and international relations, which is an interesting double major. Then came down south, spent a year at UVA and on further south to Atlanta, where she went to medical school at Emory. Then realized it was too warm down there and started her way back north through Chapel Hill for residency, and then landed in Richmond, where she did both palliative care and geriatric medicine fellowships prior to coming into the division. So Katie's role at VCUHealth has been to assume leadership of our longstanding house calls initiative and related programs, and has done a marvelous job over there, and is now enrolled as well in the MHA class. So she's going to be, running the business pretty soon, and want to welcome her to the stage and let her tell you the story of remote patient monitoring. Katie, please let us know.
Thanks, Dr. Bowling, and thank you for allowing me to speak. Let me just share my screen here and I'll get started. All right, hopefully everyone can see this. So today, again, thanks again for allowing me to talk. Today I'm going to talk a little bit about our transitional remote patient monitoring program, which is a new program. We've been trying to use remote patient monitoring technology to improve transitions of care. So objectives from today's talk, I'm going to first of all just define remote patient monitoring, discuss the origin and structure of the remote patient monitoring program at VCU, the Transitional Remote Patient Monitoring Program, and then talk a little bit about the Continuum Integration Center as well. We're going to go through enrollment criteria, inclusion and exclusion criteria for a transitional RPM program. I'm going to provide a little bit of an overview of VCU transitional RPM patient outcomes and experiences to date, and then explore future direction of the transitional RPM program and the Continuum Integration Center at VCU. So just a little bit about the basics of remote patient monitoring. So basically, remote patient monitoring technology is the use of digital technology to collect health data from individuals in one location and electronically transmit that information securely to healthcare providers in a different location who can utilize that data for assessment and recommendations for that patient's care plan. The concept of RPM and just telehealth and telemedicine in general has become obviously especially relevant in the setting of the COVID-19 pandemic, but RPM had been around even before that. Traditionally, RPM technology has been used more for chronic disease management. For example, VCU Endocrinology Division has an RPM program for some of their diabetic patients, where they have a Bluetooth-enabled glucometer, which they can use to monitor their patients' blood sugars and adjust their regimen accordingly. But our program's a little bit different. Our program uses RPM technology to try and improve transitions of care rather than for use of this technology in long-term chronic disease management. So initially, our program started, it's a pretty new program. We've been around for about 9 months. We were initially started out of concern for that first COVID wave back in March and April of 2020. Where VCU is really thinking we needed the capability to be able to monitor patients outside of hospital walls to free up hospital beds in the setting of an anticipated bed crunch and capacity issues. So 200 Dictum remote patient monitoring devices were purchased. Dr. Lanning actually had used these devices previously and had had a good experience with some of his patients post-operatively. So he and his team were really helpful initially, especially in getting us oriented and sorting out these devices and how to use them initially. There was a command center type model, which we had set up at a new satellite location, the Continuum Integration Center over on the north side, which I'll go into a little bit more detail later. And this program, initially was intended for COVID patients. but broadened out later to include other patients at high risk of readmission as well. So patients with heart failure, COPD, sepsis from urinary tract infection, pneumonia, cellulitis, and then we'd also worked in conjunction with the surgery teams for some bariatric and pediatric surgery patients as well. So I think it's important also just to note this program was really developed with a sense of urgency. We went from really, just talking about this program back and forth in emails and initial meetings to enrolling our first patient within a time span of 27 days. And we have just grown from there. Oops, sorry, this skipped ahead here. So just some basic inclusion and exclusion criteria for our transitional RPM program. They're very broad, I think, kind of intentionally, and pretty straightforward. So, patients, in order to be enrolled in this program, they need to have a stable oxygen requirement that can be met at home. They need to be hemodynamically stable, agreeable to participating, and either the patient or their caregiver has to be open to being taught how to use the device. They have to live in the state of Virginia for licensing reasons, and over the age of 18, unless enrolled in a pediatric specific pathway, like our pediatric surgery patients. So exclusion criteria, what kind of patients might not be a good fit for a transitional RPM program? Again, these are kind of intuitive. If someone's in respiratory distress, increasing oxygen requirements, severe chest pain, and their troponins are uptrending, if you're thinking they're going to need advanced imaging like CT, MRI, or any kind of surgical procedure in the next 72 hours, again, probably not a good patient for this program. If you think they're going to need lab monitoring more than once a day or once every couple of days, if they have severe acute renal failure with more than 50% drop from their baseline, again, that might not be the best patient for this program. So you can think about, these are just some examples of some patients to give you the sense of what kind of patient might be a good fit for transitional RPM program. Maybe it's that patient in the emergency department. You might be on the fence about admitting, or maybe they really don't want to be admitted, or they're at risk for complications if they are admitted, but they would benefit from close follow-up and vital sign monitoring. And you might feel a little bit better about letting them go home, knowing that they would be sort of plugged into this type of service. Maybe it's that heart failure patient whose medications and diuretics you've been titrating while inpatient. And you think they would benefit from close monitoring on discharge to prevent readmission, and might be able to feel more comfortable getting out of the hospital a day or so early if you know that there's going to be someone keeping a close eye on them when they get out of the hospital. Maybe it's that patient who came into the hospital with something, a different diagnosis, but ended up testing positive for COVID-19. They have minimal symptoms, but they're at increased risk for severe disease. Or maybe it's the COVID-19 patient who was either recently weaned off of oxygen or weaned to a stable oxygen requirement. You might, again, feel more comfortable letting them get out of the hospital a little bit earlier, knowing that this type of support would be available to them. And again, just broadly, just think of your patient without, any patient that you think might be at high risk of readmission that you would think might benefit from this type of monitoring and follow-up. So not bound to any specific diagnoses. So what does the referral process look like? If you have a patient and you think this would be someone you would want to refer to the transitional remote patient monitoring program, you can put an order in Cerner. So if you type in remote patient monitoring, you will see an option that's post-acute care. And then it will also ask you to specify number of days, and you would click 16. So the primary team can place this order. Sometimes care coordination talks to the primary team about it. And it can be proposed by the care coordinator. ER, CDU providers can place the order as well. And outpatient providers sometimes also have ordered this, like in an effort to get their patients this kind of monitoring to prevent a hospitalization. But I would say the majority of our referrals do come from inpatient teams at this point in time. So once that referral is placed, that prompts a page to go out to our enrollment team. which is a nursing team now who will contact the primary team, and they'll discuss together, what vital signs do you want monitored, how frequently, and what are the parameters. So what is the upper or lower limit of each vital sign, which would, you would want to prompt a page to a nurse or to check in on the patient and see how they're doing. Once that's set up, our enrollment team will then deploy the equipment to the patient and teach the patient and the caregiver how to use the equipment and give them a bit of an intro into the program. So this is just a picture of what the Dictum devices look like that the patients get in a little carrying case. So it's a cellular enabled tablet with a Bluetooth enabled blood pressure cuff, pulse oximeter, and thermometer. In some kits, we have the ability to give a Bluetooth enabled scale as well. There is a glucometer in this picture, which is not included in the kits that we give to patients, but patients can input their blood sugars on the monitor or on the tablet, so we can track their blood sugars in that way, and that works pretty well. Same thing if a patient has a scale at home, they can plug in their weights, so we can track weights that way. I think just one thing to note about, just to make sure to emphasize on this, is it's Wi-Fi and cellular enabled, so patients don't have to have Wi-Fi in order to use this, because I know that could be a barrier for a lot of our patients, but they don't need to have Wi-Fi in their homes. Another thing to note is this tablet, when you power it up and turn it on, this is what pops up. There's not other like apps or YouTube or Facebook or anything like that this tablet can do. So it's not complicated. It's just, this screen will pop up, and it's a lot of pictures. And once you click on the icon, it sort of also walks you through how to check your blood pressure, how to put on the pulse oximeter and things like that. So it's fairly user friendly. So then when a patient is discharged, there is the duration of the monitoring period. At this point, it's about 16 days, sometimes longer, sometimes shorter. Nurses contact patients within 24 hours of getting home from the hospital, and then every 3 days over the course of the monitoring period. The nurses are also informed in real time via text page when vital signs fall outside of those parameters that are set by the referring provider in conjunction with the enrollment team. So the nurses, when they get those alerts, they call the patient, check up on them, make sure they're using the equipment properly, that it's a true alert, not noise. And then there's a provider available 24/7 for escalation needs. And then usually we try to have the transitional remote patient monitoring provider, either an APP or physician, do a couple of visits with the patient via their tablet over the course of the monitoring period, usually one within like 3 or 4 days of getting home, and then one sort of like a tuck-in visit at the end of the monitoring period. There's also care coordination and social work support on site at the KIC as well, which is great. And that initial post-discharge phone call is actually done typically by one of our care coordination nurses over at the KIC. So it's not only just, orienting the patient to the program, making sure they got home okay, but also, assessing for any care coordination needs as well. And something we've introduced a little bit more recently to this program is we have been inviting our patients to participate in a new virtual advanced care planning clinic, which is called the Preference Bridge Clinic, which was recently started by Dr. Rachel Selby-Penzak, one of the geriatricians and palliative care doctors here, which I think has been a pretty good. Patients have appreciated. It's been a great addition to this program as well. This is a picture of the Continuum Integration Center. So this is kind of where the monitoring happens. It's located over on West Graham Road in the north side. It's actually above the VCU North Side daycare over there. So the KIC houses an integrated team of nurses and social workers who are experienced with the health system and health system aligned resources. So on top of managing the vital signs and dictum, they can also assist providers and care teams with getting their patients set up with services or resources that they would need to help manage their care more effectively. So they can facilitate ordering home health services, they can facilitate a mobile urgent care visit, mobile imaging, x-rays, ultrasounds, things like that can be done in the home, mobile phlebotomy. They can help coordinate new PCP visits, prescription assistance programs, referral to senior connections, other community resources. Just a lot, they're doing a lot of different things over there on top of just the monitoring itself. Our nursing team over at the KIC is also supporting a pulse ox monitoring program for COVID positive patients that's led by Dr. Aurora and Dr. Gong in the ER and CDU also. So that's been a great collaboration with ER and CDU team as well. Our nursing facility attending service is also housed at the KIC. So just kind of want to convey that the KIC it's about more than just the monitoring itself. There's a lot more going on over there. So, and then when a patient has completed the monitoring period, what happens? So there's a discharge phone call with the nurse. There's usually a discharge visit via the tablet with the RPM provider. And then the nurse will do sort of a discharge phone visit, make sure that they are set up with their PCP appointment. If they haven't seen their PCP yet, we make sure the PCP gets a copy of all their vital signs that were taken over the monitoring period, as well as our notes. Dictum devices can be returned via courier, like picked up from the patient's home. If they live within a 30-mile radius, can be returned via FedEx, or if patients are coming to VCU for an appointment, we can just grab it from them while they're here. Devices are then cleaned and sterilized and then prepped for use for another patient. So that is just sort of an overview of the process. And just going into a little bit about our patient population and who we've taken care of since starting in April. So from April to December 2020, we've had 357 patients. That's sort of unique MRNs that were enrolled into the transitional remote patient monitoring program. Some patients were re-enrolled. If we're looking at sort of total enrollments, it was about 450. So about a third of our patients were COVID positive, a little over a third of our patients. We had about 26 patients in collaboration with pediatric and bariatric surgery. Looking at our patients' LACE scores, our average LACE score was over 11, so 11.5, which is relatively quite high, especially if you're looking at the comparison group here, which is patients who are discharged home with home health, or without home with or without home health, that were not referred to transitional remote patient monitoring. Transitional remote patient monitoring graduates had much higher LACE scores on average. Average patient age was 58.8. Our top 3 DRGs that really account for 70 to 80% of our patient population: respiratory infection, CHF, and sepsis. And our patient population in our program tend to be fairly VCU allegiant. So I just kind of wanted to take a minute to highlight a couple of cases of patients that we've had over the last few months that have, I think, kind of illustrate the variety of different services we can provide patients. So Mr. R was a 54-year-old gentleman with refractory hypertension who was initially admitted to VCU after a stroke, unfortunately. Previously, he'd had pretty minimal contact with the healthcare system. While he was in the hospital, he was also diagnosed with heart failure, and he was enrolled in the transitional remote patient monitoring program on discharge. So he'd been started on a lot of medications on discharge, and his partner, who was his primary caregiver, had a lot of concerns and felt pretty apprehensive about the care plan. Our team really helped educate her and walk her through the process. Complicating matters, he had really tight intracranial stenosis, which was unfortunately not amenable to intervention. And he'd become pretty symptomatic with even kind of relatively minor swings in blood pressure. So his antihypertensive regimen was really carefully titrated using the TRPM data in conjugation with his heart failure and his neurology teams. In addition, he and his partner were having difficulties affording some of his medications, so our team connected him with some prescription assistance programs. He also hadn't really established care with a PCP, so we also got him set up with Complex Care Clinic, and he had an appointment set up and a warm handoff from our team prior to discharge from the transitional RPM program. And another case to just discuss. So Mr. C was a 46-year-old gentleman with type 2 diabetes, Down syndrome as well, who was diagnosed with COVID-19 initially in the ER back in the fall. So initially he was enrolled in the ER CDU ROMCOM as their pulse ox monitoring program. So they're giving him a standard pulse ox on discharge or after his test returned COVID positive, and they were just keeping an eye on his sats and calling him intermittently to check in. Symptoms started worsening on getting back home. After discussion with a CDU provider, our KIC team helped arrange for a mobile urgent care visit that day from Dispatch Health. When Dispatch Health was out there, his sats were 93, 94%. His patient and his mother really had a strong preference to manage the patient in place outside the hospital. So rather than having him come in, we were able to get a mobile chest x-ray out there that day as well. The images were sent directly to the CDU provider, which showed bilateral fluffy infiltrates, looked like COVID pneumonia versus atypical community-acquired pneumonia. Again, given the preference that the patient's mother had expressed was really to treat in place, he was started on dexamethasone, azithromycin. We transitioned him to the transitional remote patient monitoring program, just again, so we could have more vital sign monitoring than just the pulse ox. We could also keep an eye on his blood sugars now that he was on the dexamethasone. And our nurse team continued to call to check in on him frequently. Unfortunately, over the course of the next couple of days, his sats continued to trend down, though he was not any more symptomatic. And so ultimately, at the urging of our team, especially once the sats dropped, below 90, 92, we encouraged him to come into the ER, which he did. When he was admitted, he was treated with dexamethasone. He completed his dexamethasone. He was treated with remdesivir. He also got convalescent plasma, and he actually did well, and was enrolled in the transitional RPM program again on discharge. So after discharge, while enrolled on transitional remote patient monitoring, our team was able to facilitate a referral for him to establish care with a new PCP. And we also got him into sleep clinic because there was some concern for nocturnal hypoxia that might be related to some untreated OSA. So those are just a couple of cases that I think kind of highlight what we do and our collaboration also with the ER and the CDU. And then looking at patient experiences. So Dr. Haesung Kang is a surgery resident who has been helping us along with a team of medical students doing these phone surveys for patients after RPM discharge to kind of assess their satisfaction with the program, what they like, what they didn't like. So this is a survey of medicine patients, and of the 53 responses they received, 97.5% of the transitional RPM graduates said they were satisfied with the use of the device, and 94.2% said that they would recommend this program to a friend or a family member. And here are just some quotes that I thought kind of illustrated some of the feedback that we had. One of my favorites at the bottom, best idea since sliced bread. Gave me a sense of connection to help if I needed it. And I think that's something that this program really is able to provide, a way for these patients to sort of reach back into the health system. And if they have questions or concerns that we might be able to address to prevent, another hospitalization or ER visit. So I won't read through these, but just some feedback that we've gotten. And then looking at some more data, looking at what, and our program is still relatively new. Our numbers are still relatively small. So over time, we are going to continue to, collect this data but just given the, over the course of the first 8 or 9 months of the program, if we compare transitional RPM graduates in the top 3 DRGs, again, that's sepsis, heart failure, respiratory infection, and that makes up about 70 to 80% of our total patient population. to a comparison group, which is we looked at patients in those top 3 DRGs with similar LACE scores who are discharged home with home health, close to VC and VCU also. And we looked at their readmission rates. There was a 24.6% reduction in 30-day readmissions in the TRPM graduate group. Using the same comparison group, we also looked at length of stay and found a 12.9% reduction in length of stay from 9.3 to 8.1 days. So I also kind of wanted to highlight some of the challenges that we faced and some of the challenges we continue to face as we try and move this program forward. So from a staffing standpoint, this program was initially stood up as part of the COVID-19 surge. Back in March and April, we were relying on redeployed nursing staff and then supplemental nursing staff, which has been a little bit challenging just because we've been constantly having to train and retrain people as they rotate through. Similarly, we didn't have a dedicated transitional remote patient monitoring provider. So our house calls group actually has stepped up and taken turns rotating through this role, doing virtual visits with patients and being that point person for nursing staff to reach out to during the day for those alerts and issues requiring escalation of care. After hours coverage has also been a bit of an issue because we don't have a dedicated after hours coverage for this program. So we've relied initially on the geriatrics division and specifically Dr. Bowling, who has really been doing the lion's share of this for us. Technological challenges, initially just figuring out how to get the nurses to have real-time alerts sent to them. So Dictum is set up to send an alert via email if vital signs fall outside parameters, which it didn't just seem to make sense to have nurses standing by at their email account refreshing all day. So we finally figured out a way to get it sent to an email that would go to their pager. And then something that we continue to struggle with is getting the vital signs in the electronic medical record system. So Dictum doesn't sync with Cerner or Epic either, unfortunately. So this remains a challenge for us. So nurses and providers, as a workaround, have just been copying the vitals into their notes. But again, these are only visible if you're looking into the notes, and they are also scanned in under scanned documents also. But they don't sync to Cerner, so we've had to find some workarounds for that. Just in terms of coordination and logistics, initially when we were just getting started, just how to advertise the program and get the word out, the care coordination department was really helpful with this. And I had the chance to speak with some house staff as well about the program. And then something that is ongoing, we're continuing to work with other specialties in primary care. And we're often in close contact with them anyway while their patient is on transitional RPM program. But we're trying to do some pilot programs where they are actually the point person for their patients while they're enrolled in transitional RPM program. In essence, basically cutting out that middleman transitional RPM provider altogether. So for example, we have a pilot program now where the heart failure team is the primary contact for their heart failure patients who are on inotropes or their heart failure transplant patients. Similarly, we're doing a pilot program now where COM providers like COM geriatrics, COM complex clinic providers are the primary contact person for the transitional RPM nurses when their patients are enrolled in RPM. So equipment management, just the logistics around coordinating how to get the equipment back from patients, how to sanitize it, how to clean the equipment between patients. That has definitely been a challenge and a work in progress. And then just how do we fit in with, there's a lot of other transitional care programs out there. There's a lot being offered to patients on discharge. So care coordination, transition of care calls, C3RX, phone calls, home visits, hospital medicine, post-discharge visits. Sometimes if we're throwing the kitchen sink at patients, it can be overwhelming. So I think just trying to figure out ways we can be thoughtful and integrate into other sort of existing things we're offering patients. So we're not the, fourth post-discharge call a patient's getting in a day. And then just COVID related challenges. I mean, I think it's other people in the hospital have faced similar issues. This program, just COVID has provided a sense of urgency that has necessitated rapid development and scaling up, and has made us have to be creative with how we can help our patients. So when our devices ran a little bit low, if we had some patients who just needed pulse ox monitoring, we've had instances where we have just been sending them out with standard pulse ox, giving them a log and having them call us with the readings. Again, that's only in COVID positive patients who only we've only been asked to do pulse ox monitoring on. But again, just trying to be creative and trying to figure out how we can help patients wherever we can. And then obviously COVID has contributed to staffing shortages and issues at times. So future directions for transitional RPM program and the Continuum Integration Center. So I'm excited to say that we now are interviewing for some new positions in the KIC. So both the monitoring nurses, screening nurse, a nurse care coordinator over there, nurse clinician, PAR. We have a new APP who started over there a couple of months ago and is a rock star, and then 0.5 of a physician role. So I think having these dedicated providers in place will only really strengthen the kinds of things we're able to accomplish. Just having that continuity of the staff over there will be huge. I think we will just keep working on continuing to foster collaboration with specialists and primary care and others within VCU, continuing to work on quality improvement, collecting more data, figuring out, who are the patients that are really benefiting the most from this intervention and how can we get this to them? And then over in the KIC, they're trying to also put together a navigation team specifically for bundles patients as well. And then I think just something to mention also, that's not necessarily in the immediate future for this program, but this kind of command center model and, remote monitoring technology really lends itself well to even something like a hospital at home or an acute care at home a model of care too. And that's also something that has been taking off around the country, especially now in the setting of the pandemic. So it took an incredible amount of work to get this program off the ground. I just wanted to thank a few people, Dr. Lanning and Dr. Haesung Kang, who really helped us get set up in the beginning with Dictum as they were familiar with these devices, and they've supported us throughout this whole course. Dr. Mishra and his team as well. Many, many, many people in the Division of Geriatric Medicine have supported and continue to support this program, which really has allowed us to build transitional RPM program into what it is today. So from our home-based primary care NPs who spent months rotating through as covering transitional RPM provider, to our house calls administrative team who's still helping us out with a lot of our administrative duties, to Kristen Armstrong, who basically single-handedly deployed these devices for the first few weeks while we were just getting started. Not to mention Dr. Bowling, who, as I said, is taking the lion's share of the after-hours coverage for this program. And many, many others. All in all, we estimate there's been probably about 70 nurses rotating through the KIC and with our enrollment team since we got started. And they have all been trained by our fearless nurse leader, Allison Knapstein, who's going to be on in a little bit for Q&A. She's just done a phenomenal job with that over there. I just can't say enough great things about her. So this is it's been a monumental effort by a great team. And I really think one of the silver linings of the pandemic might have been seeing how so many from our division came together to support a program like this in a time of need for our health system and our patients. So that's all. I'm happy to take any questions. Oh, I see a question about cost of service delivery and when any aspects are covered by payers. Yeah, so when patients are having the visit with the remote monitoring provider, so it's a virtual visit, it's billed just like an E&M virtual visit. So that is covered by insurance like in that way. And then we've also started, we can also bill for the monitoring itself, which we've only started doing recently. It's a little bit more of a complicated process. And we're still sort of trying to figure out the ins and outs of it. But yeah, we should be able to bill for the monitoring also. Investigated other devices. So Dr. Weisberger asked a question about have I investigated other devices? Are there other data you would like to collect but can't currently? So I guess you mean other RPM devices. I mean, there are others out there that sync with various electronic medical record system. These are the ones that we have right now. So these are the ones that we're working with. It's, it's been it's been challenging at times, but there are definitely other devices that do sync with, with Epic and with Cerner and have other capabilities that Dictum doesn't. Yeah. Any other data you would like to collect but can't currently? You mean in terms of like health data? I mean, I think we're getting, I'm not sure if that was the question, is what other like health data would you like to collect? Gotcha. Thanks for clarifying. I don't know. I'll have to think about that. I mean, I think we're pretty comprehensive. So we're getting, we have the capability at blood pressure, pulse ox, blood sugar, weights, I think is huge. Temperatures really most useful for patients, COVID patients and those with, sepsis or other infections. But I think we're getting a lot of data. I can't think of off the top of my head, can't think of anything else that I wish we could incorporate. And Allison Napstein had to join a little bit late. She's our nurse leader. Allison, I'm not sure if you have anything else you wanted to add.
Hey, Katie. Sorry, I was trying to unmute myself. I was double muted there, but excited to be a part of this presentation. And I would like to add, Dr. Brennan was very flattering for, her thankfulness and the list that she gave, but she also has put a lot of work into this program, and we are very thankful for her. And it looks like I've been asked a few questions here about nursing. Throughout the program, we have oriented several nurses, and we're also very thankful for all those staff. We started with a neurosurgery nurses and that were redeployed from the clinic, neurosurgery clinic, and then they had to go back, and then we had to reorient nurses from ambulatory supplemental, and then they had to go back and help with the COVID surge. So then we were given staff from inpatient supplemental. And now we are working on getting permanent staffing. So very excited about that. And the nurses have been awesome. They've been resilient. They've had to learn and be flexible. Some of them have never done phone triage before. Some of them have never done ambulatory care in Cerner. So it was a lot. And we've learned a whole lot, and very appreciative of everyone's hard work.
Someone had asked a question about RPM device options available for patients with visual or hearing impairment. I think that's a great question. I don't know about any, so I know our RPM device, it doesn't really have the option to sort of talk to the patient, if I'm, Allison, that's correct, right? So I don't know that that's an option with our current device that we have. I know, we've worked closely with language services because our devices also only have English language settings. So we worked really closely with language services to make sure that they can work with patients so they're familiar with the device so they can help patients who don't speak English work with the device. But I'm not sure about patients with visual or hearing impairment. We haven't had any. Usually, they'll have a caregiver who can help them out, but I know that's not always the case. So that's something we'll have to look into. It's a great question.
I did get a question about what we have observed, or what the nurses have observed. I think that may be around maybe their experience. They have found that coming into RPM has been a unique experience. They've learned a lot. A lot of them are inpatient nurses, which has been an eye-opener to them as to what happens when patients leave the hospital doors. And that whole continuum of care process, and just being able to empower patients and educate them, give them awareness, and let them be advocates for themselves and know how to do that, I think has been huge for them. The nurses love it. And we're getting good feedback from the patients as well.
And a question was asked, of the small percentage of patients dissatisfied with the program, what were the reasons given by the patients? So I was just reading through some of the survey comments before this talk, just to see. It's usually the technology aspect of things, like, they didn't like the blood pressure cuff, or, they felt like their blood pressure cuff that they had at home might have worked better. We do have different cuff sizes, I will say, so we can fit patients, when we're enrolling them with the proper blood pressure cuff to that. But I would say, and I don't know, Allison, if you would say something differently, but I feel like it's usually like the technology aspect of it, that if patients are not satisfied, as opposed to like the services provided for the nursing team.
That's correct. A lot of the issues sometimes have been, or the dissatisfaction has been around when something goes wrong with either the tablet or an IT issue, and it sometimes takes a little bit of time to resolve, and a lot of back and forth calls, with the patient, and I think that gets frustrating on their end as well.
And someone asked, what is the easiest way for providers to contact the RPM team if they need parameters changed or care coordination while patient is enrolled? So they can reach out to the RPM enrollment nurses. I should have put this on a slide. Their pager is 9188 is the RPM enrollment team. Care coordination should also, your care coordinator should also know how to get in touch with them too. But if not, 9188 would be the pager. And if you can't get a hold of anybody, feel free to, reach out to me or Allison. We can always get you directed to the right place too.
And that would be the same pager ID if they're outpatient. We can do outpatient referrals as well. We would not be able to do the bedside education with the patients. We would do that over the phone, and we could have a courier send the equipment out to them, or we use a FedEx mail service to get the equipment instead of the bedside deployment.
And I think Dr. Weisberger asked about any thoughts about extending the program to patients discharged to other hospitals in the area or accepting referrals from outside VCU. I think for right now, we're focusing on VCU patients. But if you have a patient, as an outpatient provider that's been, discharged from another hospital, and, you think that they would benefit from transitional RPM, feel free to, to reach out or put in the referral. We can discuss. That's definitely an option. So it's not really, it's not necessarily a requirement that they were just discharged from VCU. So yeah, and then another great question about what do you think will happen post-pandemic with transitional RPM? Same, less, more? So I mean, I think that this kind of, obviously telehealth and remote monitoring, I think is here to stay in some capacity or another. And especially if we're seeing that this has benefits in patients beyond, just COVID patients, in terms of reducing readmissions and length of stay. I mean, I think that it will be here to stay in some capacity or another. Um, all right.
I think there's a question about patients that are already enrolled as a follow-up to a previous question. Yes, so we have a contact number for the nurses station for patients that are currently enrolled in RPM. That number is 828-1969, and that's the best way to get the RPM nurses when patients are in the program. 828-1969.
All right. Well, I think if that is all the questions, I just want to thank everybody again so much for taking the time to listen. And feel free to reach out to me or Allison if you have any other questions about the program. Thanks.
Thank you.